Good afternoon, everybody. Thank you so much for joining us today. I am just going to share my screen, which is, I think, the classic opening for any online session. So welcome to our second in our MDT Spotlight series. I'm really delighted today that we've got some fantastic physiotherapy professionals here to talk to us about physiotherapy in a neonatal setting. So just by way of introduction for this afternoon, I'm Chelsea Letts. I'm the Healthcare Engagement Programme Lead at Bliss. You've probably seen me around if you've been coming along to any of our webinars. And I'm delighted that Anna and Helen are here with me today. So Anna, do you mind just introducing yourself first, please?
Yes, hi everyone. My name's Anna Lukins. I'm one of the joint neonatal network leads for the London network, and I also work clinically at a level 3 hospital in London.
Thanks, Anna. And Helen?
Hi everyone, my name's Helen Cater. I also work for the Operational Delivery Network for the East Midlands, and clinically I work at the Royal Derby Hospital.
Lovely, thank you both very much. We'll be hearing lots more from Anna and Helen obviously over the next hour or so. We're really delighted that they're here with us today. A couple of little housekeeping bits. If you haven't been to if you didn't get to go to the first session of this Spotlight series, just as a reminder, we have a Q&A functionality which you're very welcome to use for any questions that you might have for Anna and Helen, or kind of things that crop up during our session today. There's opportunity to start discussions, so please do feel free to use those functions if you wish. There's also a chat function, so if you have any queries or questions for us as a Bliss team, or you have any technical issues, please do pop anything in there as well, and we make sure that we'll respond to those too. We have set everybody's mics up for off, just so that we are keeping everything nice and quiet, so that we can kind of all hear the discussion. But if you wanted to engage with us in terms of asking any questions a bit later on, then do just raise your hand and we'll allow your microphone, and you just need to come off mute to do that. So I think that's most things for today's programme. So we're going to keep this short and sweet 1 hour session, which is an opportunity really to understand more about what physiotherapy service it looks like in a neonatal setting. Anna and Helen are going to do a little introduction for us at the beginning, just to give us a real outline of that and set the context for the session. And I'm delighted to say we've got a short recording from a parent who had a particular experience with physiotherapy on the neonatal unit with her daughter, that we'll share with you. Again, just helpful, I think, for context to really think about the impact that these services have. And then we'll have a bit of a Q&A led by me initially, through some questions that we have based on some of the things that are mentioned kind of in the initial presentation. And then if we have time, we'll definitely try and take some questions from the audience. Thank you to anyone who's submitted questions in advance. We have tried to kind of incorporate those into that, so we'll make sure that we include those too. So in terms of today, what we want to try and get out of this session is really just to try and make sure that we are kind of increasing the awareness and knowledge of what the physiotherapy specialism looks like in neonatal care, and to empower you as healthcare professionals to support how these services are integrated into the wider neonatal team. These are going to be very similar objectives across the series, because it is so important for each of the different specialisms, because they are so important and vital to the delivery of family integrated care for every baby, which is obviously what we're all driving towards. But we know that there are some challenges around inequities of services, etc. But and we have to acknowledge and appreciate the impact that might have on the development of parental partnership as well. So quite a lot to try and cover in a short space of time, but hopefully we'll touch on all of those things and kind of whet appetite for thinking a bit more about this kind of moving forward. So that's my little introduction. I think I'm going to pass over now to Anna and Helen, who are going to do a short introduction about physiotherapy on the neonatal unit. Thank you both.
Thank you. Hopefully you can see that screen. Is that there? Yeah.
Thanks, Chelsea. And first of all, I think we'd like to say thank you very much to Bliss for this opportunity, for inviting us to come and talk and share our experiences, and provide this opportunity to talk about neonatal physiotherapy. And as Chelsea has already mentioned, we've got a brief presentation with a few slides that will just help us share with you an overview of the role of a clinical neonatal therapist on a unit, but also talk briefly around the role of our roles with the operational delivery network level. We'll also talk about our different levels of service, and that's thinking about universal, targeted and specialist approaches. And we'll talk about how we're hoping and how we're working towards embedding these principles into care on the units. As Chelsea said, we're also fortunate that we're going to hear from a parent who's had experience of having premature baby on a unit, on several units. So we'll hear her feedback. And then there's the opportunity we've got some questions, and hopefully we'll be providing the answers. So we'll just start with a little bit of information around the neonatal physiotherapy role. And a neonatal physiotherapist will aim to assess and support the development of infants at risk of adverse neurological outcomes, such as those premature infants or those with medical conditions. And we'll aim to achieve this goal through many different aspects of our work. We will carry out specific assessments and observations and interventions, focusing quite specifically on movement skills, gross motor and postural control. But we'll also be, through our handling and our positioning, thinking about encouraging the development of muscle strength, bone strength, and also trying to influence through positive handling and moving and touch those positive patterns of movement and coordination. Altogether, this really helps us individualise the intervention and care for the baby and the family, and to meet each baby's individual needs. We're consistently working alongside parents and really pride ourselves in supporting family integrated care on units. And this really helps also with multidisciplinary team working with our colleagues as well as the families. We also want to ensure that we support holistic management for babies' care, and sometimes this might include some really specific areas that we might think about: orthopedic conditions, babies in quite complex surgical situations, but also respiratory needs where appropriate. So we'll really tailor our input to whatever that baby needs at whatever time during their care. We also want to make sure that we ensure that vulnerable babies and those at high risk are placed on care pathways, to make sure that we've got follow-up and early intervention lined up for them, for a continuation of our therapy potentially into the community services. And where able, we really want to advocate and promote education, training and teaching opportunities for the whole neonatal team, but also for families. And hopefully that slide there gives you a really nice picture of everything that we try to incorporate.
So, as well as a neonatal physio on an actual neonatal unit doing the clinical role, some of you might have heard of our network roles, so working with operational delivery networks. So this came about following the critical care transformation review. They identified that there were real gaps in AHPP provision on neonatal units, and that us as AHPs are key members of the neonatal MDT, and we should be on these units, and we should be there to help to improve outcomes and to support these babies and families. So they recommended these ODN network roles, and we started in post a couple of years ago now. And we essentially work collaboratively with the wider ODN team to meet the recommendations of these national reviews. We kind of split our roles into about 4 aspects. So initially we were thinking about benchmarking what the current provision was on the units, and helping to grow the workforce, because we know that there is inequity, and we're going to hear from Liz, our parent speaker, in a little bit about her experiences on different units. We know that it's not the same provision on every unit, and actually as part of our ODN roles, what we're trying to do is highlight those differences and those inequities, and help to support the units that don't currently have physio, to build those business cases and to recognise that that is needed. And then alongside growing the workforce that we have at the moment, we provide clinical support and supervision to them. So we've developed peer support groups. There's various different educational opportunities for the physiotherapists that work on neonatal units, but also physios that want to get into neonatal physio, and raising the awareness of our roles, but also training and education for the wider neonatal MDT as well. So we work collaboratively with the whole team, and talk about how we can work as one team with one shared goal. And we have a role within clinical governance as well, so lots of audits and benchmarking on units, but also thinking about wider clinical guidelines and policies to try and make sure there is equity in care and that the standards of care are equal in all units. This is just an example, just very briefly. I won't go into detail about it, but we do have staffing recommendations for what physiotherapists should be, the level of physio that we should have on each unit. And you can see here by network that these are, the darker purple is the gap. And you can see that no network actually meets even 50% of staffing. So there are significant gaps in physio staffing. And actually a lot of these networks are kind of between 20 and 30% of where we should be. And this data is kind of relatively recent, within the last couple of months. And in terms of service delivery, so some of you have probably seen this pyramid before, and I know they talked about it last week in the psychology one as well. But we look at the different levels of kind of the different aspects of care that we can contribute to. I always like to start at the bottom of the pyramid with the universal aspects, because that's thinking about embedded principles of care for all babies. So trying to reduce those inequities and actually providing every baby and family on a neonatal unit with equitable care. And there's lots of aspects of universal practice that us as physios play really key roles in. So as Helen mentioned, we really we kind of embed phy care within our practice, and we work really closely with parents and collaborate with them and empower them to deliver therapy themselves. We will definitely support units with things like developmental care, education, discussing about different practices, Bliss Charter, BFI, and then we also have a real role with training and education on the unit with that wider neonatal MDT as well. And I think lots of people don't necessarily think about this aspect as much, because we maybe don't have that much capacity on lots of units, but we play a really key role in service improvement and quality improvement projects as well, and research. And actually there's been quite a push, particularly from BAPM recently, to try and support AHPs getting into more research. And so there's lots and lots of really good projects that come out, and actually that's one of the things that we like to promote as to how AHPs can support improving care on units through QI. And then further up that pyramid, so thinking about the targeted aspect. So as Helen mentioned, there are some babies that are more at risk of others. And so we do have some targeted models where we might screen and support particular babies that are at high risk. So it might be those babies that are maybe less than 30 weeks, or babies that have had particular kind of concerns with cardiac difficulties or neurological difficulties or something like that. And that would involve the kind of screening and provision of early intervention for them. And then we've got the specialist roles as well. So as Helen mentioned, we've got very specialist skills in supporting neuromotor development. So we can use those specialist skills for the babies that do already show difficulties, or that we know are at really high risk of difficulties. So we can support those babies with the individualised care, and support the families as well to provide that education and that support. Okay, so I think it would be nice to hear from the parent before we go into the questions. So I'll stop sharing.
Thank you both so much. And it was a really, really helpful introduction and setting lots of context for lots of the questions that we want to kind of answer today. So thank you so much for that. Really appreciate it. So as Anna said, I'm going to share my screen now for hearing from the parent that we kindly heard, who was kind enough to share her story for us to include in today's session. So her name is Liz. It's a relatively short video, but I think encompasses a lot of different elements of the really amazing things about physios and some of the challenges around the service not being available everywhere. So I think lots of interesting things to take from that. So I will share my screen now so that you can hear from Liz directly.
Chelsea, we can't hear her voice at the moment. I'm not sure if the sound's working.
That will be entirely my fault, not sharing my sound. Thank you, Anna. Otherwise, I'd have just listened to that myself. I'll try that again. Sorry, everybody. Always one technical issue, isn't there? Try again.
Hi, I'm Liz, and my daughter Josie was born in 2019 at 23 plus 6 weeks. She spent 137 days in hospital, and that was across 3 different NICUs. Physio became involved with us on the ward when she was around 2.5 months at our level 3 hospital. And initially, that was to look at positionings of her while she was in the cot, and we were shown different ways to use the blankets to do that. And then that moved on to us practicing tummy time. So he was given a mat and a mirror, and the physio helped us then to get on the floor with her and practice that tummy time. And that was a really nice experience to do with her. We got some lovely photographs of her looking at herself in the mirror, which was nice to do. The physio supported throughout that. We was given her number as well to bleep her if we wanted her to come and see us at any time. I also did some tummy time with her where I lay her across my arm. So she was on my tummy and I would move her around then a little bit so she would get the different experience of that. With all the wires and attached to her, I didn't think we could do things like that with her in hospital. I thought it was very much just looking at that care and the medical side of things. So it was really nice to do some play opportunities with her and get her on the floor, and just do normal everyday things with her as well. And it was nice for us to be able to do that together whilst we was on the ward. We were then moved to our level 3 hospital where that physio was stopped. It wasn't a very big unit where we were, our level 2 hospital, sorry. It wasn't a very big unit, so our local hospital, she was in a small cot as well, more of a plastic cot. So she didn't have a lot of room in there for us to practice those positionings using the blankets. So what I did with her more there was I would get her out and she was on me more of the time whilst I was there. I did use my feeding cushion to help sit her up on my knee as well, so she was getting that experience. And I would lie her on my chest to keep that tummy time going. Um, it would have been really helpful if we would have had more discussions at our local hospital, more so around getting us ready to go home. So encouraging us to practice different things with her, and we didn't really get any of that. But when we did get home, I did make sure that a lot of it was floor play. She didn't have any kind of the different toys you can get. We did lots of things on the mats, encouraging that tummy time. And I do think that's definitely helped her as she's got older with her physical development. It helped her with that crawling initially as well. So it was really nice to do. My confidence grew a lot more once I was able to do more of that work with the physio and just her normalising that kind of play, and us encouraging to do that with her on the ward.
So I think a huge thank you to Liz for sharing her story. I think we were reflecting just before this how helpful it is to hear, obviously directly from the family, but how her confidence really grew from being on the neonatal unit, and how much of a longevity that had for her on her journey as she was kind of going home and being discharged as well, which I think is really lovely to hear and a real testament to the support that she had on the unit. Before we go into questions, Anna and Helen, I don't know whether you have any reflections on Liz's story that you wanted to just briefly share ahead of that.
I think you've probably summarised some of our initial thoughts, and it's really lovely to hear how throughout her journey and the therapy that she received at whichever point has really helped empower her to then be able to deliver really sensitive and developmentally appropriate care for her baby. So she's taking ownership of giving her baby those opportunities and really helping support her physical development, and sort of affirming that attunement with mum and dad as a family unit. And I think that really underpins all of our principles that we'd really love to share with everyone, and hope that that's a common theme.
Yeah, I think also I really liked that she kind of highlighted about how her daughter had lots of lines and lots of kind of medical difficulties, and up until that point there'd obviously been a lot of a focus on the medical side of things. But once physiotherapy had got involved, she was able to have those really nice positive experiences and be, as Helen said, be empowered to provide different activities and developmentally appropriate activities for her baby, which is different to just lots of medically focused things. So I think that's really nice, and that's something that we really enjoy. I personally really enjoy as a physio, is being able to come in and give those really nice experiences to families, so the focus isn't just on the medical side of things.
Yeah, absolutely. Thank you both very much. So we have a few questions that we'd like to try and run through ahead of taking any from the audience, which I think will just pick up and allow us to expand a little bit more on some of the things you've already shared in your presentation. So I think, Helen, particularly when you were talking about the role and highlighting with the wheel in the middle and highlighting all the different elements of it, just shows how broad the role is, and in terms of the different areas and the different skill sets that you as physios have. I wonder whether there were any areas of your work that you feel are usually prioritised when referring to your specialism, or any areas that you feel like might be a bit misunderstood that you wanted to kind of take the opportunity to clarify today.
Yeah, I think that's a really good point, Chelsea. And maybe this has some background in sort of historical pockets of therapy on units, in which at that point maybe the approach has been, like we mentioned earlier, in the different levels of delivery, maybe has been very much thinking about that kind of very specialist approach and intervention, and thinking about the most complex neuro kind of infant, or maybe a child that's presenting with respiratory condition, or really fragile situation with their breathing. They are quite specific areas, and I think again, that's where some of our targeted and very specialist intervention has been. And quite rightly, those babies do need support and intervention, need our skills to help, tailor the therapy around everything they need. But also, I think, what's really important is what we want to try and do is think about how we focus now on some of those universal principles that Anna mentioned at the bottom of that triangle, so that we can ensure that all babies and families get a certain level of intervention, training, knowledge, skills that we can share with them, and empower them, like we heard from Liz, increasing their confidence with handling, having an awareness around the positioning and the principles and why it's going to help, why we might do these things, will then have an overlap into some of those more complex conditions. So, for example, with the respiratory, positioning is going to be really important, but it's going to have twofold two sides to it, as well as helping with respiratory function, but also from a developmental point of view as well.
Yeah, and I think as you said, Helen, I think historically, particularly if there's been limited provision on a unit, so limited time available, you do focus on those babies at highest risk, and you do focus on those complex babies. But that's a little bit more of a reactive model. So that's kind of once they've got those difficulties, or when we're noticing that there are difficulties, we're getting involved and we're supporting. But actually, by looking at the universal aspects and getting involved much sooner, we're looking more at preventative work and doing that kind of preventative early intervention before the baby has the difficulties, so it has an improvement in their long-term outcome. So just little things like, exactly as Helen said, about thinking about positioning, not just if they start to show difficulties in their, for example, if they've got a ventilator required pneumonia or something like that, and that they're starting to need some respiratory input. Actually, we should be providing that universal advice initially, right at the start. So how important it is to have regular repositioning for both neurodevelopmental and respiratory support, and optimizing their positioning early on to try and reduce the risk of that potentially happening later on, if that makes sense.
Yeah, that makes a lot of sense. And I think it's a really helpful structure to think about kind of the different levels and what's available for everybody, and that specialist, those specialist needs, which obviously are really important. But it expands the role, I suppose, into something broader that can benefit everybody. Is that fairly like a newer way of looking at physiotherapy? Because I think you implied in the presentation that this is something you're working towards. Is that something that you're seeing happening more and more, and who are you seeing kind of benefit from that, do you think?
Yeah, I think so. I think every unit is different, isn't it? And there are lots of units across the country that have been maybe fortunate enough to have an embedded physiotherapist on their unit, or an embedded AHP team on their unit for a long time. And they probably have been involved in all of those universal aspects. So they probably have been supporting education and teaching across the whole MDT, and putting in pathways and recommendations for babies early on. But I think from the benchmarking data that we collected at the start of our network roles, it definitely identified that there were massive gaps, worse than the slide that I showed you just now, because actually that's following lots of income that we've had over the last couple of years. So we've managed to generate lots more posts fairly recently, within the last year or so. But prior to that, there were huge gaps, and there were many units that had absolutely nothing, or they might have a very minimal amount of physio, and so it would probably be coming from an in-reach service. So it might be a paediatric team, or it might be even a community team that come in to provide a bit of support for the units. And because of that, I think historically the kind of focus and the priority has been on those more complex babies to provide that specialist support. And so I guess what we're trying to encourage now is, even if I know that lots of units still unfortunately don't have much capacity, and so they still have that very limited time, but it's thinking about can that time be used in a slightly different way, so it's not only focused on those specialist babies, but actually during that time can you provide something like a developmental care round, where you're going around a few babies within the space of an hour, and you're able to support those families and provide some early advice and individualized advice for those babies, but earlier on, because if you capture them early in their journey and you start to empower those parents, the parents are the consistency for that baby. So as they move through the neonatal unit, staff change, staff on shifts change, they might move to a different unit, but the parents are the consistency. So that's why it's so key that we're supporting them and we're educating them right at the start, because they can be the advocate for the baby and they can say, oh, I'm aware about the importance of developmental care principles, and my baby I know needs this particular support. We've been using this particular nest for them, or something like that. And then they can provide that support, and actually it slightly reduces the burden later on. So it's thinking about, it's still really, really important for us to have that specialist input, because those babies definitely still need that support and we don't want to take that away. But can we slightly kind of change the way that the time is used if limited time is available? Or alternatively, thinking about the other aspects of universals, and so not necessarily the clinical stuff, but the education and the training for the unit. Because actually, if you're educating and empowering the rest of the neonatal MDT and you're supporting them so that they can then provide the support for the parents, the neurodevelopmental support, then that's actually supporting every baby on the unit. You're capturing a lot more than just the one baby that you have the time to see, if that makes sense.
Yeah, it definitely does. Makes a lot of sense. I think there was one of the other questions that I was going to ask was a bit about that early intervention, which you've mentioned a few times, I think both of you. And I think you already started to kind of explain why that's so important. I don't know whether there's any more that you wanted to kind of expand on that. And also, I suppose we've already acknowledged that there are lots of units that may not have the specialist service available. So kind of what sort of it might be kind of in place for, or would you kind of encourage for units where there's a challenge around that kind of service being available, or maybe there are really limited hours available? What would you kind of recommend for that?
Yeah, so I think, like you said, we've talked about early intervention several times already, and and it's almost like inbred in us. We know how important it is, but sharing that is really important so that others can understand. But we know that there's a lot of evidence available to back us up, and it's what we use to base our therapy on and our intervention, evidence-based, so that we know that it really has a huge impact on short and long-term outcomes for babies and families. And in particular, we can talk about, there was a systemic review done quite recently that came out of Australia in 2021, and that actually provided an early intervention guideline that we can use and look at that program. But it actually really championed them, working alongside the parents, encouraging the parents to have a voice, but also to be working and setting goals, joint goals, and it. It's really helped give us a structure for a lot of early intervention programs. And then, thinking about units where there might not be full capacity or very limited hours of therapy, perhaps we're thinking towards more of our network colleagues and the network role in terms of, trying to involve senior management on the units to be linking with the network, so that the staffing gaps can be really identified. They can be held up to answer really on things like the risk register, and at that kind of level in the trusts. And we can work with trusts to help support and provide evidence to build a business case to help with increasing staffing on units. And I think that's really important, and we have a really big role there in championing the profile of our profession, but also, like we're doing today, raising the profile, increasing awareness, really sharing what we can provide.
Thanks, Helen. That's really, really helpful. I think there's still a long way to go, but as you say, like there's definitely progress being made, which is really exciting. slight change of topic, I think, but obviously in line with kind of things that we've already mentioned. You've mentioned family integrated care and the role of physios in that, and how collaborating with parents really does help like empower them. And we've seen that through Liz's video as well, how much longer that kind of confidence can kind of go on for. It's not just about the unit. And I wonder whether you want to kind of expand on how a physiotherapist role can support kind of more broadly with that, kind of maybe in a little, maybe kind of going into maybe a little bit more detail.
Yeah, so as we've kind of discussed before, the parents are obviously they're the constant for that baby, aren't they? And we know that they're the most important factor when it comes to a baby's outcome. So engagement with the parents and empowering those parents to provide the therapy is so important, and it's just a key part of our role that's just embedded in every physio on a unit. And so thinking about how we would support those parents. So ideally we would be meeting the parents really early on. So like I've mentioned before, kind of early on thinking about that preventative work. So while the baby's in ICU and they might be very tiny, they may have only been admitted a few days ago, they might be quite sick on a ventilator, etc. I think historically people have kind of not necessarily recognised the role of physio with a baby that small, but actually a lot of what we do at that point is helping to provide support around and education around how to provide neuroprotective care and developmental care. So with the parents, what we would be doing is meeting them at that point and introducing our roles, discussing kind of the differences between term and preterm and why these preterm babies do need that extra support, and essentially explaining what developmental care is. So lots of physios now might be involved in something like a developmental care ward round, like I mentioned before, which should really be MDT focused so that you've got a holistic view from the whole MDT. But from a physio aspect, we would be particularly thinking about how we can support that baby's position, give them that kind of containment, give them that security. So using equipment for supportive positioning to help bring them into that nice flexed symmetrical position, almost trying to replicate what we can get in utero as best as we can, and discussing with the parents the importance about the environment, what they can do to support their baby at that point, because they probably think, my baby's so tiny, they're in an incubator, they look incredibly vulnerable, I shouldn't be touching them. But actually parental touch is so important, and it's in the middle of all of these negative experiences that this baby is getting during that time. Parental touch is a positive experience. So we do lots and lots of work with promoting skin to skin, so encouraging these babies to come out even if they're really sick, doing it as an MDT and making sure everyone feels confident to help support those transitions. If the parent can't do skin to skin for whatever reason, doing things like positive touch and hand hugs, and just discussing how that parent can actually be involved at that early stage and how we can start to give them that confidence with the positioning and the handling of their baby, and just simple things like they probably don't realise that their voice is so important, and reading to the baby, things like that. So there'd be lots of work that we could do at that early stage. And then as they start to get a little bit further down, so more into the HDU side, and they get a little bit bigger and they're off respiratory support, that's when we would come in to do the kind of surveillance, the specialist assessments like Helen mentioned before. So by doing these specialist assessments, the kind of screening assessments, we're potentially identifying little kind of early difficulties that we might be seeing, or what the baby's kind of strengths are and what their difficulties are, and working with the parents at that point to then tailor our recommendations to them. So it might be recommendations around positioning, it might be around interaction with the baby, it might be around kind of little activities and early communication that they can do. And then as they start to get more towards kind of working towards home, we would be providing that early intervention programme, the individualised programme, and just really hearing from the parents how they feel their baby is doing, what their strengths are, what their goals are, what they would like to work towards. So as Helen said, in those early intervention recommendations, it really highlights the importance of shared goals. So we should be discussing with the parents what their key priorities are and what they would like to work towards for their baby. And then as they're kind of getting closer to going home, there's going to be a lot of anxiety around what do we do once we go home? We haven't got all of this support from the neonatal MDT, and it's a very different environment. And so helping prepare them for that as well. And I think also in terms of expectations, the neonatal journey is almost never linear and smooth, is it? It's often very up and down. And I know that in the psychology webinar last week, they were talking about that and how much support that they need with that. And so obviously we work with the wider AHP team to help provide that support and make sure the right professionals are involved. But we can potentially work towards kind of managing their expectations a little bit. So discussing how the journey might look and potentially discussing how their outcomes might be looking when they're a little bit older and once they've left the unit. So if the baby is kind of at high risk of having difficulties, what that might mean and how much extra support they might need in the community and once they've left the unit as well. So yeah, it's really kind of involving the parents at every point.
Yeah, which I think is ultimately where we want to try and get with so many different elements of neonatal care. So I think that's really helpful, Anna. Thank you for highlighting that. Just you mentioned parental touch, and I think it would be amiss of me to just not mention that Bliss has got some relatively new information about parental touch, which I'll try and link in here in case that's useful for trying to engage with families about that and kind of support them and make them feel like that's definitely an option for them. We've actually had a question through the Q&A, which is kind of related, so I thought I'd just bring that in now if that's all right, which is about are there ever barriers to parents being able to engage with physiotherapy that's offered, and if so, what are the barriers and what can we do to overcome them, which I think is a really helpful follow-on question, so I hope you don't mind.
I mean, I think perhaps one of the most obvious barriers is sometimes a language barrier. But you know, I'd like to think that we'll try really hard to do everything we can to support with the language, the differences in the language. So it might be that we use interpreters, we might use a language line, we might use an app. There's also other programs available, like there's one called Card Medic where some of the information is written down in different languages. So you know, I think that's my obvious thought around barriers for intervention. But you know, I think, you know, and maybe different learning styles as well. But and I think, you know, this is really important that as physios, we build a relationship and a rapport with parents. And as Anna said, you know, we're trying to get involved as early as possible in baby and parents' journeys. And so one of the things that I think can be really highlighted is that often we're one of the constants, as well as the parent, obviously, you know, with our nursing colleagues, with our medical colleagues, you know, shift patterns change, you know, and staff often change quite regularly, whereas from a therapy point of view, you know, we're often the constant. So we build that relationship, we learn as we go along with every conversation, every interaction, every opportunity that we're there with the parents. We're starting to already build a picture of their level of understanding, what helps with their understanding, how to tailor that really specifically for their needs. So, for example, you know, is it that they really need photographs of certain, you know, their baby in the different positions, where to place their hands, that kind of thing? You know, is that really helpful for those specific parents rather than just verbally or demonstrating? You know, maybe they need something just to help them remember just that little bit more detail. But, you know, we talk about demonstration as well. Maybe it's that we'll demonstrate different ways to support your baby, to handle your baby, the different positions. We might use, a doll, for example, which helps parents also with their confidence in terms of handling, because maybe that's the stage before actually handling or having, that contact with their baby. Is there anything else anything else come to your mind, Anna?
Yeah, I think one of the other barriers, obviously, a lot of the time, I think, is around parental presence. So whether they're actually able to be on the unit as well. And there are so many factors with that, aren't there? It might be financial difficulties, it might be kind of problems with travel, it might be accommodation, it might be that there's other siblings at home, which there often are. And so I mean, there are various things that units and charities can do to help support with that in terms of financial support and things. But from a physio perspective, I think one thing that's really difficult is that often we work 8:30 till 5 or whatever, and we work during those working hours. And so particularly with dads that have had to go back to work, half the time we can't see them because they will come in the evenings after work. And so unfortunately we don't necessarily get to build that relationship sometimes with these parents if they've got work commitments or they've got childcare commitments or whatever. And that is a really difficult barrier, and something that I haven't necessarily kind of been able to tackle yet. But there are ways that we can have communication with parents even if they're not actually there in front of you as well. So I do lots of phone calls to the parents to discuss, either see if there's a potential day that we can plan a day for them to come in, so we could do a joint session, or if they're really not able to for whatever reason, providing information over kind of emails or over the phone. And lots of units are really fortunate to have things like Baby Diary or VCreate as well. So we can send communication with families, we can send photos. So we might be doing a therapy session, and if the parent isn't able to be there, we can take a photo of that session and say, oh, look, your baby was in a chair today, or something like that. So there are ways we can try and communicate with parents, even if they aren't actually physically there as well. But in an ideal world, I think we'd have a bit more access to kind of slightly different working hours or something. So maybe some time in the evening so that we could actually capture parents. But I can't see that happening in the near future.
No, that's been really helpful, and actually really ties into what I was going to ask next about kind of individualizing care. And I think so much of that is about understanding the needs of the family and really understand, like, what are those barriers, like what can we do to really support you to feel involved in your baby's care. That's such an important part of care as well. I think, like, making sure that if they're not able to be there and there's a barrier to that, understanding what that barrier is and trying to break that down so that they can feel involved and empowered. I think that's been really, really helpful. So thank you so much for your question on that. I don't know whether there was anything else in particular that either of you wanted to mention about kind of individualizing care for family needs, or whether we've got a few other questions that have been sent through in advance that I thought we could go through, and actually another one in the Q&A, unless there was anything else you wanted to add.
I think maybe just a point around, really encouraging multidisciplinary team working, and, case discussions and updates around individual babies, because that will really help consolidate that individual care and that approach that particular baby needs and that family needs. So there might be things that the whole team needs to consider, or that there's an approach that the whole team follows so that it's the best for that family, and that will also help with delivery of information and making sure that communication is really everybody's saying the same thing, and it's but it's also really clear and consistent, because I think that is probably a really big point that a lot of families, I think, maybe might comment on and say, sometimes communication is different. One person will say one thing, somebody says a different thing, and they're left then not knowing which is which. So I feel that's a really strong, that's something really important.
Yeah, and it's a really nice example of how collaborative working can really impact on that experience. Are there any other particular kind of good examples that you've seen kind of practically on a neonatal unit where that collaborative working is working really well that you could share?
Yeah, there's I've got a few examples from kind of units across my network that I've heard of. I think I've already mentioned them, but doing things like developmental care rounds or nutrition rounds or feeding rounds or something like that, often there's a full MDT involved in that. So you'll have various different AHPs, you'll have medics, you'll have nurses, you might have a member of the Phy Care team, you might have some extra support like chaplaincy or something like that. And by kind of having that full team around that baby and that family, when you're going round to the bed spaces and looking at how we can support that baby, you're really providing that nice holistic view from everyone. So you're providing individualized care to the baby and the family that's optimal for them. But also it's a really nice learning opportunity for the MDT as well. Every time I do one, I learn something new from the colleagues that I'm with, because every baby is so different. You hear different things at each point, and so it's an educational opportunity for MDT as well to learn from each other. And because we're all there and we're saying the information that we're giving is in front of the whole team, we're then giving that consistent message. So like Helen talked about, you don't have that inconsistency with communication and different messages being given from different teams. If you're doing joint working together, you are all saying a similar message as well. So that's a really lovely example. I think even just having the opportunity to have chances to do like complex case discussions and things like that, and making sure you have those multidisciplinary conversations and meetings with each other, so that you can hear the viewpoints of everyone that's involved with that baby. I know from experience that kind of historically, I think there used to be a lot of a medical focus, particularly for the babies in ITU, because they would be thinking kind of there and then, how do we support this baby there and then with their medical needs? But actually, with AHPs involved, often we can give that slightly broader view of actually we also need to think about their outcome, and we need to think about their future and what we're doing now to help support that and improve it in the future as well. So again, that's a really nice learning opportunity and a way for everyone to kind of come together and hear from each other. I'm not sure if you've got any other examples you wanted to mention, Helen.
I think in my network there's also a nutritional and developmental care ward round, so very similar to your developmental care ward round, but just making sure there's a focus also on nutrition and early feeding. There's also a social psychosocial ward round that occurs where the psychologist tends to lead that. So again, like pulling the MDT together and maybe having a slightly different focus, but actually, you know, the principles will all be around supporting the family, embedding you know, family integrated care, and really putting the neurodevelopmental needs of the baby as a priority. So I think, yeah, that's our focus.
Yeah, that's really helpful. Thank you. A question from somebody in the audience today. They've asked about whether a level 1 and a level 2 neonatal unit can coordinate with a level 3 unit in the ODN to ask for help and input for the babies that need physiotherapy in those level 1 and 2 units that might not have a physiotherapist. So I think this relates to some of those practical challenges about like where to prioritize services and like how to muddle that through at the moment when that's not something that is kind of fully staffed, as you demonstrated right at the beginning. So I wonder whether you've got any thoughts or comments on that at all.
I think maybe at this point I'd say, you know, try and contact your ODN therapist lead as well, because you know, if it was Anna or myself, we'd really try to think about highlighting and offering opportunities for peer support, for supervision, for you know, sharing ideas, sharing best practice. Something that works in one hospital might actually benefit another hospital or another trust in your network, or even across networks. We can learn from each other. There's no need to reinvent the wheel often. So and like we've talked about, a lot of the principles are shared. So it might be a way that you receive your referrals, it might be a way that you deliver your training or your education. Maybe we can share resources. Maybe, you know, one of the other hospitals or therapists has already developed a package of training for the doctors or for the nurses, for example. I see, you know, that is very much around the network therapy therapists, trying to support all of the therapists at the different levels of units, but trying to ensure that we work together as well and we help each other. I'm sure there absolutely can be some, be contact between the level 1, 2 and 3s for handover, for getting an update on where they're at, the situation, particular things to learn around that individual baby, like we've talked about, tailoring their individual intervention around the family's needs, things that have cropped up during the different points of their care that is useful and really beneficial to pass on, so that the family are not having to repeat the story all over again, and also so the therapists are not starting from right back at the start.
Yeah, Anna, I wonder whether I'm sure you've got something else to add, but would you mind just sharing? I think you've got a slide where you've got I feel like that might be a good opportunity to just share those contact details. So if you are a unit that wants to explore some of the things that Helen's mentioned, then these are your go-to people, I think. I don't know where, sorry, Anna, I jumped in. Did you have any other comments you wanted to share on that?
Yeah, no, absolutely. I think Helen's covered most of it. Just that I think we know that it can be quite isolating for people in kind of level 1 and level 2 units sometimes, because the funding is often much lower, and it might just be a single neonatal physio, or it might be a single paediatric physio in the whole district general hospital that in-reaches to the neonatal unit. And it can feel quite isolating, I think. And so one thing that we really want to promote within these ODN roles is that working together, exactly as Helen said. So having that communication, sharing those resources, thinking about kind of some units think about parent passports or baby passports, so that the baby has the same information that moves with them as they move through units, but really kind of accessing support from each other as physios on different units, so that we're not working in isolation and that we are sharing our skills and sharing our knowledge. And some units, if there's capacity, they might kind of have the opportunity to invite people to come and shadow for a day, so that they can see what happens on a level 3 unit, so they know what happens before that baby gets to their unit, something like that. And obviously every unit is going to be different, so we can't kind of say it's the same thing for everyone, but definitely contact your ODN lead, because they'll be able to support you with ideas and thoughts around that.
Brilliant, thank you so much. I think hopefully that's a really helpful resource. So if you are one of those units that might be struggling a little bit with that capacity and with that resourcing, then I think the ODN leads would like to hear from you, I think is fair to say, so that we can kind of work on all that together. Brilliant, thank you all so much for your questions that we and the ones that were kind of sent through in advance. Hopefully we've been able to cover quite a lot of those. We have a little bit of a kind of roundup just to close, but I think the one question that we probably haven't touched on too much is just talking a little bit about follow-up services. I appreciate we've only got a couple of minutes now, but I think there's challenge around capacity on the neonatal units, but I think also kind of that's something that I know quite a few units are struggling with, is thinking about like what happens within kind of relationships with the community team and follow up. I don't know whether there's any kind of work that's ongoing to think about that a bit more, whether that's happening at ODN level or within your networks, that you'd be happy to share before we close.
Yeah, it's definitely something that is being considered at the moment. The priority so far, because of the various kind of Ockenden reports and things like that, has been on the acute side. But I think lots of you might have heard of BANFU, so the British Association of Neonatal Neurodevelopmental Follow-up. They're a subgroup from BAPM. They look at follow-up services across units. They did a benchmarking project, and lots of neonatal networks are wanting to kind of benchmark and look at that information a little bit more, to see which units are meeting BAPM standards, which ones aren't. Unfortunately, the majority of units aren't. But also, I know personally from my network that we're trying to do a lot more collaborative working between community and acute teams, because the follow-up may be covered by acute, it may be covered by follow-up, it depends where the kind of funding sits and things like that. But actually collaborating a lot more and having those discussions about how we can support these babies early on, it's definitely something we're working towards. It is a work in progress. But there are various projects going on trying to tackle that.
Thank you. I think, yeah, it's all a bit of a work in progress, isn't it? But going the right way, which you said already, which is really reassuring.
Yeah.
Thank you so much. I think, were there any further resources that you wanted to share before we close?
Yeah, just this one. I think lots of you might have seen these before, but we've got on our APCP, so that's the Association of Paediatric Chartered Physiotherapists, we have a neonatal committee. So on our website, we have lots of resources. We've got the good practice guide for physios. That's in the process of being updated as well. So hopefully around the end of the year, we might have a new version of that. We've got our physio staffing recommendations. And then on the NHS Learning Hub, so what used to be Health Education for England, I think they're now NHS England Learning Workforce Training and Education, something like that. They help support development of some modules. So we've got freely available online modules for training and education for neonatal physios. We've got foundation and enhanced levels of that.
Amazing. Thank you very much. Really helpful to have those links. Brilliant. Well, I think we're kind of just coming out to the end of the hour. So I think a huge thank you to both Anna and Helen for your time and for giving us so many insights in kind of this short and sweet session. Please do feel free to contact, I think, your kind of ODN leads to explore that a little bit more. And obviously, if we can do anything as Bliss to support with thinking a bit more about physiotherapy and what that looks like on the neonatal unit, do reach out. We have lots more sessions coming up in terms of webinars, so please take a look at our website if you found this helpful. We're exploring each of the individual specialisms on their own merit, which is really exciting. It's a really lovely opportunity, so please do sign up for those, and we'll shortly be sending out the recording of today to everybody who registered, and also asking for a little bit of feedback on the session, just so that we can continue to improve, and there's opportunity to kind of pop your name down for getting a certificate as well for attending, so it's always a little bonus. But yes, just a huge thank you, I think, to Anna and to Helen and to Liz for sharing her story. So I think that was hugely helpful for us all, kind of sharing that opportunity, like getting that experience to really kind of put us in that mindset of kind of what that means for families, and to the Bliss team for kind of helping get this all up and running. So yeah, thank you all so much for your time, and we hope to see you again at another session very soon. Take care.
Bye.
Thank you. Bye.